Hello class, this is Lisa Peden and I'm recording a PowerPoint on care of the patient with problems of the central nervous system, specifically the spinal cord. The first disease we'll be talking about is multiple sclerosis. This is a chronic degenerative progressive disease of the central nervous system. You can see the picture here shows the progressive demyelination of the axons, which results in an impaired transmission of the nerve impulses along the axon. There are many different causes. The book says it is an inflammatory disease, but there's also an autoimmune mediated process. We also think that there may be a viral component, such as Epstein-Barr, which has just recently been discovered. We know it does run in families and that there may be some environmental issues associated with multiple sclerosis. It affects young adult women more often between the ages of 20 and 50 years old. And again, I want you just to take in this picture. The myelin, remember, is the substance that helps move the impulse along from nerve to muscle. And in multiple sclerosis, these patches of demyelination slows the impulses. And also, when you see the test results, you will see the word plaques used, and that's because this shows up as plaques on MRI. There are three major types of MS. The first and most common is the relapsing remitting type. This means that symptoms develop and then may resolve and the patient return to baseline, but then they relapse and the symptoms develop again, and you have sort of a cyclical nature of symptoms. Primary progressive is the type that has a very steady and gradual decline in function and the patient does not return to baseline. Secondary progressive begins with a relapsing remitting type process and then becomes progressively debilitating. And then progressive relapsing means that every time the patient has a relapse, they are worse and they never get back to baseline. But again, we're going to be talking about the most common type, which is the relapsing and remitting type. Multiple sclerosis is a very difficult process to diagnose. Some of the very early signs include changes in motor skills, changes in vision, and changes in sensation. Patients often say after they're diagnosed that they have had many of these symptoms for years, but the symptoms disappeared and they were not diagnosed at the time. But the symptoms are fairly vague at the beginning. The patient is very fatigued and weak. They may have some numbness or some decreased temperature sensation or some tinnitus. They may have some coordination difficulties and balance issues. They may complain about their legs being weak. Visual disturbances is often one of the first symptoms. They either have blurry or double vision or just a decreased acuity in their vision. And then in the later stages, some of them do have bowel and bladder dysfunction. Remember that this is a disease characterized by exacerbations and remissions. New symptoms may appear and existing ones may worsen. A relapse is often associated with periods of emotional and physical stress. And the book says that hot, humid environments and hot baths can cause exacerbations. I like this picture because it shows the very widespread nature of the multiple sclerosis symptoms. It can literally affect almost any body part with slowed nerve impulses and conduction and the symptoms that go along with that. So I want you to study this, and again, I'll just note that visual symptoms are sometimes some of the first symptoms of MS because the optic nerve is affected. Again, I want you to understand that the diagnosis to multiple sclerosis is very difficult because it looks like a lot of different things, as you can see from all those symptoms. The most sensitive test is the MRI, which will show plaques in the brain and spinal cord, and these are actually the areas that are being demyelinated. A cerebrospinal fluid electrophoresis may be done after a lumbar puncture. These elevated IgG antibodies will appear in 95% of the patients with multiple sclerosis, which again just confirms that we know it's an autoimmune disease. They may have elevated protein in their spinal fluid and elevated white blood cells. They may also have evoked potentials on EEGs. They usually use a visual evoked potential, and these are slowed, again because the optic nerve is often involved. The bad news is that there's no cure for MS. So our goals are to delay progression of the disease, manage chronic symptoms that the patient has, and these symptoms may be different for every patient. We want to treat acute exacerbations, and we'll talk about how we do that in just a moment. Prevent complications. And because it's a chronic disease, usually of younger women, we need to manage the psychosocial issues that come with that. Now, the pharmacological therapy for multiple sclerosis is very complex, and they are developing new drugs literally every day. Some of the older drugs are the interferons, beta 1 and beta 2. They are immune modulators. They modify the course of the disease. They have somewhat of an antiviral property that may protect the brain and spinal cord. Copaxone, or the generic name you see there, is a synthetic protein similar to myelin, and it has been shown to be useful. Some of the immunosuppressive agents you might see used are prednisone, Imuran, and Cytoxan. These decrease the number of circulating immune cells and slows the autoimmune damage to the axons. Steroids such as Solumedrol may be used for acute exacerbations to decrease the inflammation, but they would not be used long term. The others category is where your book talks about much research being done. The first one, natalizumab or Tysabri, was the first IV monoclonal antibody. It binds to the white blood cells to prevent further damage to the myelin. Gilenya was the first oral immune modulator, and it's still widely used. The bradycardia that comes as a side effect potentially during the first 6 hours requires the patient to take their first dose while sitting in the doctor's office, and then they must be monitored on telemetry for 6 hours before they're allowed to leave. Tecfidera and Aubagio or newer drugs that inhibit the immune cells and have an antioxidant property that protects the brain and spinal cord. And the side effects of these last two are facial flushing and GI upset. Now, nursing care also is very complex. These patients may need some gait training and mobility training. They may need muscle stretching to decrease the spasticity and contractions in their muscles that are innervated by the diseased neurons. They may need relaxation and coordination exercises. If they have difficulty in their throat muscles, they may need speech and swallowing assistance or evaluations. They do need frequent short rest periods, though, because of the overwhelming fatigue. Some of them may need to have an eye patch on one eye or the other, or alternating because of the double vision that they may have. If they're having voiding issues, they may need to be on a voiding schedule where they go every 2 to 3 hours, or they may even have to teach themselves intermittent self-catheterizations. But we do need to be sure and promote self-care. These are usually women who are taking care of a family, so they need to take care of themselves also. We need to get them adaptive devices. This may be a hand splint if they're having trouble with their hands. It could be a foot drop splint. They need help with problem solving and planning for home care. And then there's many complementary or alternative therapies such as massage, yoga, acupuncture, and meditation that your book mentions. Okay, the next process we're going to talk about are spinal cord injuries, and the statistics on spinal cord injuries are just staggering. We have 18,000 new injuries per year in the United States, and these occur predominantly in males, young males, between the ages of 16 and 30. Young men account for 80% of all spinal cord injuries. 35% are caused by motor vehicle accidents. Falls are the second leading cause, and violence is the third most common cause. And one that is increasing is sports-related injuries. The risk factors, besides age and gender, no surprise, are alcohol and drug use. And the peak time for injuries is summers, weekends, and holidays. The vertebra most frequently injured are C5, T12, and L1. And that's because we have greater spinal mobility in these areas. Now, these patients may survive their initial injury, but they will have a decreased life expectancy due to things like infections, septicemia, pneumonia, and urinary tract infections. So it goes without saying that prevention is very important. This is just some more elaboration on the types of injuries that can cause spinal cord trauma. We know that motor vehicle accidents, especially head-on and rear-end collisions, falls, especially if a patient strikes their chin or falls onto their buttocks. Other accidents like diving into shallow water or taking a blow to the top of the head are some other etiologies of spinal cord injuries. I've already talked about sports, violence, either low impact or high impact violence like stabbings or gunshot wounds. Now, in the elderly population, if they have osteoporosis and sustain a compression fracture or fragility fracture, this could injure their spinal cord. And of course, spinal tumors could injure the spinal cord, but again, motor vehicles accidents, falls, and accidents are the major ways that people damage their spinal cord. These are some of the mechanisms of injury, and you see some of the same pictures. Hyperflexion is caused by a sudden and forceful acceleration of the head forward, such as with a head-on motor vehicle accident or a diving accident. Hyperextension occurs with a chin strike usually, or a patient fall, or if the vehicle is struck from behind. A hyperextension injury stretches and tears the ligaments, maybe causes a fracture in the vertebra, and damages the spinal cord. An axial loading or vertical compression may occur from diving or falling onto your buttocks, taking a blow to the top of the head. All of these cause the vertebra to shatter, and pieces of the bone may damage the spinal cord. An example of an excessive rotation injury would be caused by turning your head beyond the normal range, and you can see how that could happen if you fell off the back of that horse and hit the fence. A penetrating trauma would be from a knife wound, which would be a low impact injury, to a gunshot, which would be a high impact injury. Another classification for spinal cord injuries is complete and incomplete. Complete injuries result in all motor or movement and sensory or sensation below the level of the injury being destroyed. An incomplete injury actually is more common. It allows for some function or movement below the level of the injury. And the deficit seen with each of these type of injuries varies according to the level and type of injury. You may have heard of Brown-Séquard syndrome, or an anterior cord injury, or a central cord injury, or a posterior cord injury. These are all examples of incomplete injuries where the patient may have sensation or movement or bits and pieces below the injury level. Quadriplegia, or as your book calls it, tetraplegia, is an injury at C8 or above. This results in a loss of movement and sensation in all four extremities and the trunk. Paraplegia would be an injury at T1 or below, and results in loss of movement and sensation in the lower extremities and all or part of the trunk. And obviously, the higher the injury, the less sensation and movement is going to be preserved. Cervical cord injuries, or quadriplegia, accounts for about half of all spinal cord injuries. C1 and C4, C1 through C4 lesions will result in intercostal muscle and diaphragm paralysis. Patients with a C1, 2, or 3 injury will be mechanically ventilator dependent. At C4, which is around the level of the clavicle, the patient may be off the ventilator for short periods after they have been rehabilitated. And some of you may remember Christopher Reeve, Superman, and his injury was at C4. And that's why in some of his later years he was able to be off the ventilator for short periods of time. But anyone with a C3 or above level injury will be mechanically dependent on the ventilator. At C5, some people will have hand-to-mouth coordination, especially if they're using aids. At C6, some recovery of the triceps may enable the patient to drive. And then at C7 and C8, the patient with a lot of rehab can become independent because they may have latissimus dorsi and trapezius movement, which enables them to be able to use their hands in sort of a general matter. They wouldn't have any fine motor movement. Other landmarks on the paraplegia side, T5 is at your nipple, T10 is your umbilicus, and L3 innervates your lower limbs and saddle area. Below S3, there is no paralysis but loss of sensation to the saddle area. So what I've tried to do here is just to give you some landmarks of where a patient's injury is, and then on their body where they would be affected. Okay, during the very acute stages immediately after the injury of a patient who has a suspected spinal cord injury, of course we want to focus on the ABCs. Airway, breathing, and circulation, especially important if the patient has a high cervical injury. The next priority would be neuroassessment with a Glasgow Coma Scale score. We want to be sure and immobilize these patients at the scene because anyone with a head or neck injury must be considered to have a spinal cord injury until it's ruled out. So we want to immobilize them on a backboard and avoid any twisting of their neck or any movement en route to the ER in case they may have a fracture, but they may not have a spinal cord injury, and we want to prevent that. They do need to be transported to a trauma center, and so helicopter rescue and transport is often recommended in these patients. They need to be in a specialized spinal cord injured ER. The first thing they're going to do is x-rays to see if the bony spine is involved, and then they may do CT scans and MRIs to see what the cord involvement is. Now, the next bullet, the high-dose steroids, is in blue on purpose. This intervention for the last 15 to 20 years has been thought to salvage spinal cord, help patients recover better and fuller, but it actually has gone very much out of favor now, and in fact it wasn't even in the new IGGI textbook. We used to think that if we gave them these high-dose steroids, and in the ER, in the ambulance, this would be Solumedrol, that the cord would have less inflammation around it, and we could salvage the spinal cord function somewhat. But in the way of evidence-based practice, this has been studied very much, and there were no real differences in outcomes when these patients received these large amounts of steroids. So as I read about this on other sources, it said it really depends on the physician in the ER and the setting as to whether he wants to initiate the high-dose steroids as a medico-legal type situation, but that studies recently have shown that there is no big effect to giving these high-dose steroids. We do want them to have oxygen because it's the same scenario as putting oxygen on a heart victim. You're supplying the myocardium with more oxygen. In this situation, we're supplying the spinal cord with more oxygen. Remember, if they have a cervical spine injury, especially at C3-4 above, they will need to have mechanical ventilation. So we want to keep the patient's PO2 as high as possible so that the spinal cord does not become ischemic. If these patients have a broken neck, if they have a fracture in their C-spine that could potentially harm the cord, they will be put into skeletal traction, and that spine will be immobilized, and I'll show you some pictures of that. Now again, these would be used if the patient had a fractured neck. Not all spinal cord injured patients have broken vertebrae, but many of them do. The type of skeletal traction we would put them in is called Gardner-Wells tongs, and these are pins that are actually screwed into the skull and then attached to a skeletal traction system. So you see your weights, you see your pulleys, you see your ropes. This patient would need to be probably in a rotorest bed or something with a overhead frame on it so that the traction had a place to attach. Best case scenario is that if the patient does not have cervical cord injuries but has a fractured C-spine, they can go into a halo vest or traction, which is a type of ambulatory or static traction. And I'll be showing you a picture of that in just a minute. But please know that the vertebral column or the bony column has to be stabilized before we can work on the spinal cord, because obviously the bone could damage the spinal cord. Okay, this is a rotorest bed. It is a oscillating bed, which means it turns from side to side. The patient is held into place with cushions and straps, and with the slowly turning, oscillating type movement, it keeps the patient halfway free of things like atelectasis, pneumonia, urinary tract infections, and this has pretty much replaced the striker frame and circular electric bed that we used to see in some old pictures. Now, this patient would most likely be in an ICU. These beds are heavy, and so if you ever see one of these, please do not try and work it yourself. Always get some help the first time. This is the halo traction, which is a kind of ambulatory cervical traction. This patient does have pins in his skull, but those are secured to a vest. We want to do pin site care daily around those pins, and it's the same concept that you will do this according to your hospital policy. You want to inspect the skin around the vest daily and make sure that the patient's not getting skin breakdown. Now, I want you to think if the patient needed chest compressions or CPR, you can see that this hard vest covers the exact area where you would need to have your hands. So these patients usually have an Allen wrench taped to their vest, and so if you needed to do CPR, you would need to have that vest removed, and usually that requires a wrench. So everything we do in taking care of this patient, we want to keep them from choking or arresting. So small things like cutting their meat, cutting their food into very small pieces so that they don't get choked could save you from having to take an Allen wrench and undo this vest and try and do CPR. Now, if the patient falls, and these patients are usually ambulatory, so they're up walking with these halo vests. If they were to fall and one of the pins in the scalp became dislodged, you would want to hold the patient's head in alignment until you could get a physician. You would never try and replace the pin or replace the halo vest or do anything like that. If a pin becomes dislodged, you want to hold their head and neck in place and get help. You never want to use the upright bars on this apparatus to move patients up in the bed or to roll the patient from side to side. And it's very tempting because they are heavy, they're top heavy, and sometimes they don't move very well themselves. But you would never use the upright bars to move or roll them. The way you can do daily care or hygiene under this halo vest, and they're usually lined in sheepskin, and they do get a little bit smelly and sweaty. You can slide a clean pillowcase between the vest and skin daily. It helps to sort of absorb some of the odor and sweat. But you can also see when you pull the pillowcase out if there is any drainage or blood on that pillowcase, and if so, then you would need to be investigating what was happening under that vest. Okay, now these patients are going to go home with this halo traction in place. They may be able to walk, but remember, they're going to be very top heavy. They need to have a cane or at least a walker to start out with, and we're going to need to teach the patient and family how to take care of these pins and teach them, not to lift or move the patient holding on to his halo device, and how to clean it. So there would be quite a bit of some family teaching involved here. All right, now if the patient does need to go to surgery after a spinal cord injury in order to stabilize the spine, they may need to have rods inserted in their spine. They can't stay in traction forever, so they may need a spinal fusion. But after that surgery, we would need to continue respiratory support and cardiac monitoring, medication therapy, and individualized care, and treat them like another surgical patient with an added spinal cord injury. These are some of the complications of spinal cord injury pretty soon after the injury. Spinal shock is basically just what it sounds like. The spinal cord is in shock. There is complete loss of motor, sensory, reflex, and autonomic function. It occurs shortly after the injury and may last from 48 hours to several weeks. It's characterized by, again, loss of deep tendon reflexes, loss of sphincter reflexes, loss of sensation, and flaccid paralysis below the level of injury. Neurogenic shock, on the other hand, is more the entire nervous system being in shock. Remember, the spinal cord is the information highway from the periphery to the brain. So a disruption in the spinal cord causes disruption in the sympathetic nervous system messages being relayed. So the patient's flight or fight response is lost. So when the sympathetic nervous system is unopposed by the parasympathetic response, you get peripheral dilation, venous pooling, and a decreased cardiac output. Patients in neurogenic shock are hypotensive, so they need fluids. They are bradycardic, so they may need atropine. We may use volume extenders like dextran, or we may have to use dopamine. They also may have a temperature regulation problem. So again, Spinal shock is more just the spinal cord being in shock, whereas neurogenic shock is more like the entire nervous system being in shock. Now, these patients are going to be immobile for quite some time, and so we do need to take care to prevent deep vein thrombosis. They need low dose anticoagulation. We need to do range of motion on their lower extremities. We need to put them in TED hose and monitor for deep vein thrombosis. They may have orthostatic hypotension also in the first 2 weeks. Blood pressure again is going to be very unstable. They've lost their reflex arcs, so we must raise these patients up very gradually. They may need to use a tilt table in physical therapy, and we may need to put thigh-high TED hose on them to improve their venous return. Neurogenic bladder means that reflexes to the bladder are lost, so the patients have no awareness of the need to void. So they may get urinary retention. So they need to be either intermittent catheterized or have a indwelling Foley catheter. Autonomic dysreflexia is a very severe complication, and it can occur even years after the patient has their spinal cord injury. It is an excessive, uncontrolled sympathetic nervous system output that is caused by some kind of noxious stimuli. Now, this stimuli may be a distended bladder, it may be a impacted bowel, it can be a tear in the skin, it can be as simple as an ingrown toenail, but it causes this overreaction of the sympathetic nervous system. The patient complains of a very severe headache. They have a very, very increased blood pressure. They become very diaphoretic and sweaty above the level of their injury, and they may even have goosebumps. They may become nauseated. They may have some nasal congestion, and they may be bradycardic. So it is considered a neurological emergency. The first thing we want to do is to raise the head of their bed. This will decrease their blood pressure. Secondly, we want to start looking for the source of the stimuli. Many times it is a distended bladder, a Foley catheter that has become clogged or has become kinked off for some reason. For some patients, it's a bowel impaction, and if they can get their bowel disimpacted, their symptoms will resolve. Sometimes it can be as simple as something being caught on their skin between the sheet and their skin, such as a needle cap or something in their bed. So we just really need to elevate the head of their bed and then start looking for the source of the stimuli. Some of the longer term complications are things like bladder and kidney infections due to stasis from the catheter. Remember, these patients can't feel any kind of dysuria, so they can't really tell us if they're having, pain or burning or stinging. These patients need a bowel program to keep their bowels from becoming impacted. They need stool softeners. They need increased fluids, increased fiber in their diet. And some may need some kind of way of emptying their bowel every day or every other day. Sometimes this can be a suppository, sometimes this just requires some digital stimulation. Spasticity is another problem. Remember, this is increased muscle tone, and this is problematic in rehab because Patients can't be exercised. Spasticity usually peaks within the first 2 years after the injury and then regresses. So during these 2 years, they may need baclofen, antispasmodics such as Xanaflex. Pneumonia is a real issue or a real problem as far as complications. Remember, they have decreased innervation to their diaphragm and to their intercostal muscles, especially the higher their spinal cord injury is. They have a poor, weak cough. They may have a trach if they've been on the ventilator. So we must do everything we can to help with their pulmonary toilet. Your book talks about cough assist, where the nurse pushes inward and upward over the area over the diaphragm as the patient coughs. We need to do suctioning as necessary. We need to do incentive spirometry if that is possible to prevent pneumonia. Pressure ulcers and sepsis, obviously this is going to be a problem, so we need to keep the patient assessed and off of their bony prominences as much as possible. Osteomyelitis would come later after a pressure ulcer perhaps had become infected, and depression is going to be something that we're fighting constantly during their recovery phase. Okay, we're going to talk about nursing care, a little bit more about assessment. Some of these things I've already covered. We want to be sure and assess their skin, make sure they have a good bowel and bladder program, and that we are positioning them appropriately so that they don't get contractures that could impede their rehabilitation. And we want to help family and see what kind of family coping mechanisms the patient has and assess that from the beginning. With interventions, we want to do muscle strengthening. We want to increase their exercise as they can tolerate it. They may need braces or crutches. Some of the lower spinal cord injuries may be able to walk with braces and crutches. We want to encourage weight bearing for those who can tolerate that, because remember, when we weight bear, we prevent osteopenia and osteoporosis. Now, they may need transportation modifications such as wheelchairs and vans. The new thing in your book was called this functional electrical stimulation, which uses small electrical pulses to the paralyzed muscles to help restore or improve their function. So that is the new thing, functional electrical stimulation, and they are being used in the rehab setting. Now, with skin integrity, we want to encourage the patient to use mirrors to check the parts of his body that he may not be able to see. We definitely want them to have pressure relief every 2 hours, even if this means the patient does push-ups with his arms in his wheelchair. We want them to have clean, wrinkle-free beds and wheelchair cushions, and they need good nutrition. With bladder management, remember they may have a neurogenic bladder, so we want to be aware of that. We want to make sure they have at least 2.5 liters of intake of fluids per day. They need to have frequent bladder emptying. Now, this may mean intermittent catheterizations. It may mean a Foley catheter for a short period of time, or it may mean just triggering the reflex that empties the bladder. And this can be done by stroking the inner thigh of the patient to trigger a reflexive emptying of the bladder. They need perineal and perianal care. External catheters for males, maybe, and also the new Daisy appliances that we're using in the hospital. We want to monitor for symptoms of urinary tract infection because remember, they don't feel this. So we're looking for cloudy or foul smelling urine. We're looking for fever or chills. We may be able to teach the patients to catheterize themselves. And worst case scenario, if the patient had perhaps very bad skin breakdown or a wound that needed to heal, they might need a urinary diversion such as a urostomy or an ileal conduit, but I would think that we would try everything possible before we got to that point. Some of our interventions as far as bowel control may be things such as a bowel training program, anal sphincter massage every 48 hours, and it's most effective if that's done after meals. We want to make sure that we are monitoring for symptoms of impaction, and that usually is sort of some loose watery fluid that's coming out around the impaction. They need to be on a high fiber diet and again lots of PO fluids. Sexual expression, there is a need for counseling because we know that these injuries do happen in younger men, I guess, and women. There are things that they can do, they can use, such as prostheses or Viagra. For females, I need you to know that pregnancy is still possible. They may begin to ovulate as early as 6 months after the injury. Coping mechanisms, we want to always foster hope. And help them overcome a sense of futility. Some of the emotions after a cord injury, of course, are shock and disbelief, denial, reaction, mobilization, and then eventually coping. So we want to help with that process, help teach them and promote self-care and independence. Which is the goal of rehab, is to promote as much independence as possible. Now remember, spasticity is this increased muscle tone in the muscle that is weak, and this spasticity usually occurs below the level of the spinal cord injury. So we do want to treat them with antispasmodics such as baclofen, Dantrium, Valium, and Xanaflex. We want to help them with passive range of motion, which also will help decrease spasticity. Infection and potential for sepsis can come from various sources, lungs, urinary tract, pressure ulcers. So all we can do to prevent these is important. We want to teach them to stay away from other people who are sick because their immune system is compromised. They need to have a flu vaccine. They need to stop smoking. They need a high protein diet. And if infections do occur, then they're going to need antibiotics. But remember, this is a major cause of death, infection leading to sepsis, which will end their life. Okay, then when we get them to the point where they are able to go home or go to an alternate living situation, we want to do as much family teaching as we can about skin care and catheter care and range of motion and breathing exercises. We want to have someone do a home environment assessment. They're going to need, handicap access. And then for people who will be able to drive, it is possible to have their vehicle modified so that they have ramps that go into the car, and then all the driving mechanisms are on the steering wheel. I have actually seen a van like this, and it was fascinating. And this is the place where I need to remind you that there's lots of people that are going to be involved in this patient's care. We're going to have occupational therapists, we're going to have physical therapists, we're going to have speech therapists and case managers. And so remember what you know about the differences in the roles of the occupational therapist and the physical therapist. Occupational therapists work on activities of daily living and fine motor movements, usually the things and exercises from the waist up. And then the physical therapist will work with mobility and use of lower extremity devices. Now we're going to talk about low back pain, which is a leading cause of work disability and loss of financial independence. There's lots of causes for low back pain. Many causes for low back pain. A lumbar sacral strain, weak muscles, osteoarthritis, spinal stenosis, disc problems, all of these. I won't read them all to you, but I do have obesity in bold because obesity is one of the largest contributing factors to low back pain. If this low back pain is caused by a musculoskeletal problem like osteoarthritis, it will usually become worse with activity. I said that it caused a lot of work disability and loss of financial security, but can also cause dependence on alcohol and analgesics. These are some definitions of different degrees of low back pain. Acute low back pain is pain that lasts less than 4 weeks. Subacute back pain lasts from 4 to 12 weeks. And then chronic, persistent low back pain is a pain that lasts more than 3 months without improvement. Radiculopathy and sciatica are nerve root pain that originates from either a herniated disc or a herniated nucleus pulposa, and we'll talk more about that. This just means that there is nerve involvement and that it's not just bony pain. Some of the diagnostic procedures you could expect would be spinal x-rays, just gold standard x-rays. Patient then may have an MRI or CT scan to see if there is disc or cord involvement. They might have a bone scan to show if there are other issues. They might have electromyographies and nerve conduction velocity studies. Non-surgical management would be teaching the patient positioning techniques. The position we use with low back pain is called Williams position. This is a semi-Fowler's position with the knees flexed with a pillow underneath the knees. They may use analgesics, and we'll talk about some of those in a moment. Epidural analgesics, where they actually inject medication into the epidural space, or so that they can get some central relief, heat and cold therapy, physical therapy, exercises, again, weight control, because we know obesity is one of the big things that aggravates low back pain, yoga, and then TENS, which is a transcutaneous electrical nerve stimulator. Some of the medications for low back pain would be the NSAIDs, like ibuprofen. Tramadol, or Ultram, is a mild opiate which may be used, mild being the key word. Duloxetine is a selective norepinephrine reuptake inhibitor. You may have learned about that in your psych readings. And duloxetine can help with some of the neuropathic pain that comes with low back pain. When patients have had low back pain chronically, persistently, they may also become depressed. And the duloxetine helps with their pain, but may also help with depression that comes with this pain. Some of the skeletal muscle relaxants that you might see used with low back pain are the same ones we've just talked about. Tizanidine, which is the generic name for Xanaflex, and cyclobenzaprine, which is Flexeril. Your book is careful to talk about stronger opioids not being recommended for patients with persistent low back pain because of the chance of abuse and addiction. Another thing you might see used are the topical sprays, gels, creams, lidoderm patches, so I'll include those here under medications also. Some of the nursing interventions for low back pain are first prevention. We want patients to participate in regular exercises, a regular exercise program, which will strengthen their back muscles and help prevent them from having an injury. Some examples of these would be swimming and walking. So prevention is aimed at helping the patient participate in regular exercise. Some of the other interventions are to teach them diaphragmatic breathing and diversional activities, just trying to get their mind off their pain. Sometimes if they will get into a curled position or a fetal type position, this can open up the space around maybe a disc or a nerve that is impinged. We want to teach them how to lift. We want them to lift with their legs rather than their back. And we want to teach them weight reduction. Even a 10% weight reduction can help their pain. Some other tips, we want to teach them to avoid high heels, so our women. Patients need to make sure that their workplace is ergonomically designed. Make sure that their chair is the right height and their chair has good back support and that kind of thing. We want to teach them to stop smoking. We know that smoking is not good for our bones. And to increase their calcium and vitamin D intake if these are low. So all of these are things that we can teach the patients to do to prevent or treat their low back pain. After all these conservative measures fail, a patient may need to have back surgery. And I have always been taught, and it has held true, that you need to do everything possible before you have surgery on your back. And I believe that. But there are some newer procedures, some less invasive procedures that are giving patients with persistent low back pain a lot of hope. Orthopedic surgeons and neurosurgeons will do surgery on your back. We have the minimally invasive technique procedures, which is MIS procedures, where they use smaller instruments, they have smaller incisions, they may be assisted with lasers and small scope-like instruments. Your book also talked about robot-assisted procedures and how much the robots are really helping decrease our operative time, decrease our incision times and sizes, and helping the patient not to have to stay in the hospital so long. There are some open procedures which we are doing less and less, but we still do occasionally. The first one is a discectomy. This is the partial or complete removal of a herniated intervertebral disc, and you can see in the top picture where the intervertebral disc is bulging at the bottom and how it is pressing on the nerve in the spinal canal. The partial removal would focus only on the part of the disc that is impinging on the nerve root, and this is sometimes performed. A laminectomy, which you see in the bottom picture, is removal of the part of the bony vertebrae to open up the space so that the disc has more room. A spinal fusion is a technique where one or more of the vertebrae are fused together to stop the motion between them. Sometimes they do use screws in these areas, and they may need to use bone grafts to pad up these areas. An interbody cage is also a newer procedure where they implant a cage type appliance with a bone graft around the cage, and this fuses and prevents so much movement between the vertebrae. The minimally invasive surgeries and some of the robot-assisted surgeries may not even need to spend the night in the hospital. Many of them are being done now as same-day surgeries or less than 24 hours surgeries. But if we have patients who have discectomies or who have laminectomies or some of these fusions, we may have them in the hospital. In this case, we need to do frequent vital sign and neuro checks every 4 hours, and I'm talking about neuro checks of their extremities, making sure they can move them, that they have sensation, and that it is equal from side to side. We want to assess their sensation, again, strength. We want to assess their bladder and bowel function because many of the nerves in the sacral area especially affect our ability to void and have a bowel movement. So we want to be sure and document if the patient is able to void. Pain control maybe with some opioids immediately post-op and then progressing on to something by mouth. We want to always check their dressing because obviously no matter how short or long the incision is, there's a potential for a spinal fluid leak. And so if we see the back dressing or the neck dressing getting saturated or getting damp, we need to make sure that that is not spinal fluid. We would check that with a dextro stick or see if we had a halo sign on the bed. These patients that have the open surgeries sometimes must wear a back brace or a corset after surgery, and if so, we need to help them learn to don, D-O-N, put on the brace, and doff, D-O-F-F, remove the brace. To get out of bed, the patient should lie on one side and push up to a sitting position, and then the second person should ease their legs over the side of the bed. To log roll them in the bed, we need to roll them as a unit and not cause any bending of their back. Your book does say that these patients should not have an overhead frame and trapeze, and you can kind of understand that you don't want them reaching up for a trapeze and pulling on that immediately post-op. They need to have good respiratory hygiene, incentive spirometry, temp monitoring, deep breathing, and they need to have DVT prevention. For these open procedures, I've always been taught that for the most part, post-op, the patient needs to be lying flat or standing. They do not want them sitting up in like a semi-Fowler's or high Fowler's position for any period of time, because obviously you can tell where all of that weight would go right to the area where there was surgery. So we need to be lying or standing, but no prolonged seating. Moving on to cervical neck pain or high back pain, a lot of the principles do still apply. They can be due to a herniated disc in the cervical spine with nerve compression. You can have neck pain due to muscle, tendon, or ligament strain, incorrect lifting, a tumor or an infection can cause cervical neck pain. Now, the picture you have there is cervical radiculopathy, which is the patient has neck pain that radiates down one arm or the other, and this indicates cervical nerve impingement. The same diagnostic test will be used as we use with low back pain: X-ray, CT, MRI, and EMGs and NCBs. Conservative treatment of cervical neck pain includes wearing a soft cervical collar, which you see in this picture, especially at night, the use of hot and moist compresses, and exercises taught by the physical therapist. Pharmacological therapy would include NSAIDs, pain medications, and muscle relaxants, much like the low back pain patients. And sometimes they will use a short course of steroids to see if they can cut the inflammation around those nerve roots and see if they can get the patient some relief. But this would be a short-term steroid burst. Now, there are several surgical procedures for cervical disc or cervical pain. To get to this area with all of the surgeries here on necks, you can take an anterior approach where you go through the front of the neck, or a posterior approach where they go through the back of the neck. Now, with these anterior approaches, the incision would be in the neck area, around the trachea, around the esophagus, around the large vessels. So a posterior approach would be safer, but some people do have anterior approaches. The AICF and the LICF are the anterior or lateral interbody cervical fusions. These are the newer procedures now. They are minimally invasive. They use a titanium mesh implanted into the space where the two discs are compressing, or maybe where one has been removed, and they stabilize this with a cage and screws. The ACDF is an anterior cervical discectomy with fusion. This would include bone grafts, and the patient would need to wear a brace pre-op and sometimes post-op. These are called hard cervical collars. These are also called Miami collars or um, Philadelphia collars, I believe. Um, because of the location of the incision with these anterior procedures, airway is always the priority. So you want to assess the patient for hoarseness, which would indicate laryngeal nerve damage. Um, you want to assess them for dysphagia, difficulty swallowing, and for any esophageal, tracheal, or arterial injury. So please know the priority here, especially when you're going through these anterior approach procedures. These patients don't really stay in the hospital a long time either, but they are instructed to do no lifting for a period of time. They must be able to take care of their incision. These patients need to walk daily, obviously, to prevent the problems of immobility, and they need to know how to don and doff their brace, which in this case would be the harder Philadelphia collar or Miami J collars.